This video will serve as an introduction to the antidepressant drug classes that are available to treat major depressive disorder. Even though there are several pharmacologic classes of antidepressants, many features are shared across all pharmacologic classes. Therefore, it's worthwhile to consider overall overarching principles regarding antidepressant drugs. These will include things like mechanism of action, their clinical effects, side effects and warnings, pharmacokinetics, and overall considerations. Following this introduction, the next set of videos will cover specific antidepressant drug classes one by one. As a refresher, the pathophysiology of major depressive disorder includes two primary hypotheses: the monoamine hypothesis and the neurotrophic hypothesis. The monoamine hypothesis states that decreased brain levels of serotonin, dopamine, and norepinephrine are causative of depressive symptoms, whereas the neurotrophic hypothesis states that increased stress and cortisol lead to decrease in the release of neurotrophic factors like BDNF and subsequently reduced neurogenesis. In reality, both hypotheses are correct, and aspects of each contribute to the expression of major depressive disorder. However, what is most important for understanding antidepressants as a drug class is the decrease in monoamine levels that are seen in individuals with depression. And that's because the majority of, if not all, antidepressants block some combination of presynaptic reuptake of serotonin, norepinephrine, and dopamine. And that's depicted in this schematic here, where you have a norepinephrine nerve terminal and a serotonin nerve terminal. Normally, these neurotransmitters are released into the synapse and taken back up via their specific transporters, NET for norepinephrine and SERT for serotonin. The majority of antidepressant drugs we will talk about inhibit one or both of these transporters. Some antidepressant drugs have slightly different mechanisms or some combination of reuptake inhibition with another mechanism, but in general, all antidepressants block NET and or SERT. I will keep returning to this figure as we talk about the individual drug classes to remind you of the pathophysiology and the overall mechanism of each pharmacologic class of antidepressants. Here is another overview of the drug classes we will talk about as antidepressants. As I mentioned, all antidepressant drugs block some combination of presynaptic reuptake of serotonin, norepinephrine, and dopamine. Drugs that block serotonin reuptake primarily are the selective serotonin reuptake inhibitors, or SSRIs. Drugs that inhibit both serotonin and norepinephrine reuptake are the serotonin norepinephrine reuptake inhibitors, or SNRIs, and the tricyclic antidepressants, or TCAs. There's a set of drugs that have what I'm calling a weird mechanism, which is some combination of effects on transporters and receptors. These include agents like bupropion, mirtazapine, trazodone, and vortioxetine, among others. Then we'll talk about drugs that actually, instead of inhibiting reuptake of serotonin and norepinephrine, inhibit their metabolism, inhibit their breakdown. And these are the monoamine oxidase inhibitors, or MAOIs. And then finally, we'll talk briefly about some drugs that can be used as augmentation agents to add to an antidepressant when a single antidepressant alone as monotherapy is not effective. And these include the atypical antipsychotics and esketamine. In the antidepressant drug class, there are many agents. The figure on this slide is demonstrating over many years how many head-to-head comparisons there have been between different antidepressant agents and between antidepressants and placebo. The size of the circles indicate the number of studies that have compared these agents, and the thickness of the lines indicates the number of studies that have compared the two agents that the line is connecting. In general, what you can glean from this image is that the majority of studies have compared fluoxetine to placebo, where fluoxetine is an SSRI, and paroxetine to placebo, which again is another SSRI. The SSRIs have been tested most commonly compared to all other agents listed here. Let's talk about some of the general antidepressant considerations. First is their mechanism of action. I've already stated this several times, but again, to be very explicit, all antidepressant drugs block some combination of presynaptic reuptake or metabolism of norepinephrine, serotonin, and dopamine. It's important to note that with antidepressant drugs, their clinical effects are to alleviate the symptoms of depression. They don't cure depression, they merely eliminate symptoms. Symptoms do respond in a very characteristic order that is worth mentioning here. After about 1 week of drug therapy, usually the anxiety and insomnia are improved. After about 2 to 3 weeks, many of the neurovegetative symptoms are improved, including loss of energy and other somatic symptoms. And it usually takes until this 2 or 3 week period for a patient to feel any benefit from a antidepressant. It takes about 6 to 8 weeks for the mood symptoms to improve, including anhedonia and depressed mood. It's the 6 to 8 week point where patients would feel any mood benefit from the drug. This is important because an effective trial of any antidepressant drug must last at least 4 to 8 weeks, given this long timeline for suppression of depression symptoms. There are many adverse effects in common with almost all antidepressant drugs. First, we'll talk about side effects. Many of the antidepressant drugs prolong the QTC interval, and therefore, anyone taking an antidepressant is important to watch for additive QT prolonging effects with other QT prolonging drugs like methadone, as well as many cardiovascular drugs. Because almost all of the antidepressants increase serotonin signaling, they can increase the risk of developing serotonin syndrome. Therefore, avoiding multiple serotonergic medications is important. Other serotonergic drugs that we've talked about already include the ergots and the triptans. Next, it should be avoided to use antidepressants concomitantly with anticoagulants, antiplatelets, NSAIDs, and some natural products like St. John's wort, because this can increase bleeding risk. And finally, most antidepressants do produce dependence and can result in a discontinuation syndrome upon abrupt cessation. And therefore, almost all antidepressants require tapering over several weeks to avoid a withdrawal syndrome that includes anxiety, agitation, insomnia, and dizziness. In terms of warnings for antidepressants, all drugs approved for the treatment of depression carry a black box warning about the increased risk of suicidal thinking and behavior in children and young adults up to the age of 24. This is because of the long timeline for reversal of mood symptoms. Initially, when an antidepressant is started, after a couple of weeks, energy is improved. And because of this, during that time, anyone with suicidal thoughts or suicidal ideation often has enough energy to now carry out the actions that they have planned. Whereas previously, they may have felt so fatigued they were unable to carry out any suicidal behaviors. In the first couple weeks after starting an antidepressant, with the enhanced energy and the depressed mood still active, this is the time when suicidal thoughts and behaviors may be increased in any patient, but especially in children and young adults. And therefore, individuals should be closely monitored in the first few weeks of therapy. In terms of pharmacokinetics, most antidepressants have very similar pharmacokinetics with some slight differences that I will talk about when I get to individual agents. But in general, given that all antidepressants can be administered via oral tablet, they have very similar pharmacokinetics. This includes very rapid oral absorption with bioavailability usually somewhere between 50 and 90%, depending on the drug. Peak levels of antidepressant drugs are typically achieved within 2 to 3 hours. Most antidepressants have significant plasma protein binding and undergo hepatic metabolism and renal clearance. When I get to talking about individual agents, I will mention where anything deviates from this pattern, because even within a pharmacologic class, there is significant variability between individual agents. And the main reason for this is that even within a single pharmacologic class, there are multiple different chemical classes, and each of those chemical classes can have different pharmacokinetics as well as activity. There are many different antidepressant drugs, but in general, the differences between agents in terms of their efficacy are actually very small. All antidepressants on the market are effective in reducing the symptoms of depression, as evidenced by the figure on the left. As you can see, all antidepressants listed have significantly improved efficacy compared to placebo, and that's demonstrated by the blue boxes. Again, to reiterate, all antidepressants have efficacy compared to placebo, and differences between agents in terms of efficacy are relatively small. However, there are significant differences between agents in their adverse effect profiles, and therefore, what works for one individual may not work for another individual given these side effects. That's demonstrated by the figure on the right, which shows acceptability or dropout rate, which is a measure of how significant the adverse effects are. As you can see, compared to placebo, almost all antidepressants have non significant results in terms of acceptability. That's because over a large group of people or over a population, in general, the acceptability is not different than placebo. To stress one more time, in terms of antidepressant drugs, differences between agents in terms of efficacy are relatively small, even between drug classes. But there are significant differences in adverse effect profiles, and therefore, this is often one of the most important driving factors when selecting an antidepressant for a given patient. After listening to this overview of antidepressant drugs, now is a good time to make a list of the key features that are common to almost all antidepressant drugs. These are important things to commit to memory as you start to work through the different antidepressant drug classes and between individual agents. Try to limit your list to no more than 10 items so that it's easy for you to remember these key features.